there are some several components. So now, so these are the series of the events that we okay. So now we are just here. So we prepared for the follow-up, which will be held in the coming December. This is December, the middle of December. So we start from household census. Okay, in the household census, we cover the Suba South, all households in the Suba South. Then, okay, this is a map of Suba South, and each dot is indicate the location of the household. Then, okay, then by collecting the information of the households in the Suba South, we define the clusters to implement the cluster randomization. So then we created we defined 92 clusters. That each cluster the appropriate use of the preventive method and also transmission mechanism of the malaria and so on. So then after that, the people drew a scratch card. Then after watching the video for the among the treated households, so again we asked them about the malaria quiz. So actually we want to know whether our information was delivered properly to the people. So then we did the malaria quiz again. So then, after that, we did some simple survey. So that is the workflow. So because of this workflow, we can evaluate how well our knowledge enhancement intervention delivers the information of the malaria. Okay, so that's the way. Then, so, so this is a quite immediate impact of our intervention on their knowledge level. So 70% of respondents who watched the video reported they learned a lot. And then 25% answered that they learned something new, Okay. Then the before and after watching the video, the correct answer rate improved by 50%. Yeah, I think it's big impact. Also in the survey, in the intervention stage, we asked them about the willingness to pay for LLIM. How much do you want to pay? Actually, way of asking is this way. So will you buy a net at a certain level of price? Okay, so if, their perception was changed, they might show the higher level, higher valuation of the net. So then this is a finding. The treated households, which mean that they watch the video, show a higher willingness to pay. And then actually there was no significant difference between the control CCT and RNIS cluster. Okay. So then we can recognize. Reminder visit. So this was economic intervention was done in June and July 2022. Then, since that follow-up is like 6 months after the intervention. So in between, so we wanted to remind them about our project. So it's possible that they forget about when we come. Then we did a reminder visit. Then in the reminder visit, so we again collect some information from the ground. Okay. So in the reminder visit, we visited 1,654 households in Suba South, and then we conducted a very simple survey, like a 15-minute survey. Then we asked about the use of bed nets on the previous night of the visit, and also the malaria episode in the previous 3 months of the household members. So then, okay, let me share some tentative findings from the reminder visit. Okay, the self-reported malaria incidence in the last 3 months was 21.1%. And then, okay, so the most important finding is this one. As we found a significant treatment effect on the self-reported malaria incidence. So actually, we observed a 5 percentage points reduction by our treatment. So those who watched the video and then those who are involved in the rewarding scheme, their self-reported malaria incidence was lower by 5 percentage points. Okay. So this is our project. So now we are at this stage, the follow-up survey. So now we are preparing for the follow-up. So in the follow-up, we will do the blood sampling and also we will do the survey. So we collect about several information from the households. So we are really interested in seeing the blood sampling results, whether we have a significant impact or not. Okay, thank you so much.
Thank you, Prof, for the intriguing talk on the behavioral aspects of controlling malaria. I think these are some of the most complex questions that you can ask, but they're the ones that make the difference as well. So I'm always fascinated by the behavior and economics team and what they're trying to get at. So I think this brings us to the end of this session. I'll take it back to the main chair, and thank you everybody for your active participation.
Thank you, session chairs, for running us through that session. I'll allow you to pass. What we planned for you in the evening is so great that we need a little bit of time to prepare for you. We need about 30 minutes or so to do the dinner. We have dinner, and then for those who know how to shake some legs, you get the opportunity to also shake the legs. And there are other more things that I cannot describe in an academic session, but they'll all be available. So I wanted us just to spend the next 30 minutes as we prepare, just to listen to 3 speakers. We've agreed they'll do about 10 minutes each. But before that, I don't know whether you need 5 minutes to stretch your legs. You know, sometimes it's always good to stretch legs, because what is awaiting us? You know, need leg stretching now. So we can stretch the legs for 5 minutes, then just come here for 30 minutes. Then after that, we are ready for dinner and everything. Okay? So just stretch for 5 minutes. Thank you. Thank you for this session.
My name is Landrine Mugisha. The first show the incidence of malaria per 1,000 in 21 dans la province sanitaire by province, and we know that presque toutes les provinces avaient une incidence supérieure à 400 pour 1000. Et ça, c'est le schéma qui montre la mortalité avant l'âge de 5 ans, l'évolution 5 ans avant l'étude, l'enquête sur l'enquête démographique de la santé qui a eu lieu en 2016. Next. In our national strategic plan, which will end in 2027,
there only. We see in each province according to the National Malaria Control Program recommendation, pregnant women should receive 4 times the IPT with the combination of cephaloxane and uric metamine. However, the survey shows that only 1 out of 2 women receive a single dose, and only 2 out of 100 women receive all 4 doses of the IPT. That is to say, the coverage is very, very low. And also, the National Malaria Control Programs recommend blood testing for any child with a fever. If malaria is present, the healthcare provider should prescribe ACTs as the first line of treatment. But the survey shows us that of children with a fever, only 22% receive a blood test for malaria, and among them, only 9% receive ACTs. Other anti-malaria not recommended by National Malaria Control Program are widely prescribed. And where are we in DRC? We hope that we describe the above. We can say that we haven't yet achieved elimination. We are still fighting to control malaria. And with what we see with this survey, Mike survey,
hello, Professor.
We can say that the road is very still.
Hello,
long.
Professor. We've given you 5 more minutes to summarize. Thank you. Continue.
Okay. Thank you. Let me summarize. To summarize, I want to say that many health providers don't adhere to National Malaria Control Program recommendations. That's why there is no significant change since 2018. And so I think that there is a very big need to strengthen control measures or to integrate new measures. For example, in our daily practice of medicine, we have noticed that the number of malaria cases decreased drastically during the dry season and increased right after during the rain season. This situation is due to the drying up of the water collection that are formed after rains, preventing the growth of mosquitoes. And for me, it is surprising that malaria control policies don't sufficiently integrate environmental remediation measures that don't require much resources compared to other interventions. People prefer to spend a lot of money on costly interventions that have shown their limits. For example, instead of preventing the growth of mosquitoes, people prefer to let the mosquitoes grow and then try to fight them by using mosquito nets that most of the community does not use. I think it is time to rethink the malaria control policies to move towards a true elimination of malaria. Thanks a lot.
Thank you very much, Professor, for that great presentation. Back to overall chair, and in case of any questions, we will get back to you.
Okay, thank you.
Oh, so the next presenter will be done. This is the last presenter for today. He is Dr. Edwin Onyango, County Malaria Control Coordinator, Busia County, Kenya. Welcome, Dr. And as you prepare to present to us about the malaria situation in Busia County, current interventions, challenges, and proposed mitigations. Thank you.
Thank you so much. All protocols observed. Good evening. Yes, once again, my name is Olucho Nyango. I'm sincerely humbled to make a presentation this evening, being the last, but they saved the last for the best. I'll not even take 10 minutes. I'll take less than 10 minutes, but I'll drive the point home. So, looking at the list of the presenters today, the prefix starts mostly with prof, and I said, oh my God, is it humbling to be amongst the presenters today. We have learned so much, especially my colleagues from the county, as we work at the county, and there are a number of representatives here. I'm so happy I was not asked about my profile, because I'm not sure what I could have said. Most of the presenters here said when I was in Ghana, Sierra Leone, South Africa. So I don't know if I was asked where I have been to. I'll save that for another day, but I was born and brought and working in Western Kenya. So our presentation, the counties for other countries is equivalent with a district, a province, or a region, depending on the country. The whole world wants to eliminate malaria. So they usually at high level, there are policies, there are very high level researches like this one, but the implementation is usually done at the districts, counties. That's what you call where the rubber meets the road, isn't it? So we are going to present this and just tell you what we do. I'll mainly concentrate on routine data, that's the outline. And Busia County, you all know, is one of the counties among the 47 counties in Kenya. It borders Uganda, borders Congo, so you can explain why Busia still has got the highest burden at 39% prevalence. That's the map. I hope it is moving. This is the beautiful map of Busia. So on this statistic, the most important thing is the total population is 964,000. It will be important when we'll be discussing the cases. The malaria is still our highest percentage in 2019-2023. And in all the interventions, we are almost doing everything right. But we are asking, how come our burden is still very, very, very high? You can see we do all this. We do case management. We are not even near elimination, so we are not doing anything. We do a lot of SBC, social behavior change, and then we do a lot of monitoring. This is surveillance monitoring and evaluation, operational research. We do a lot of this, and the leadership, we have got operational research. We do a lot of this, and the leadership, we have got commodities, but the burden is still high. One question we want to ask for the researchers, of all these interventions, kindly guide us. How can we check which one has got the highest impact in controlling the malaria burden amongst this? Then, now we have got a number of partners and we really appreciate. I was told that pictures speak loud. So sorry if you cannot see your logo here, but we appreciate the support. I'm sorry I didn't put JICA because I'm not sure whether we have JICA in Busia, but I hope next time there'll be JICA. So these are the logos. You can see you have a number. Let me take some time here. I think I'm almost done. We all look at what we call annual malaria incidence to check our burden. Busia County, you can see. This is Busia. I'm comparing 4 counties. Busia, Homa Bay, Migori, and Mombasa. Busia, Homa Bay, and Migori are both classified as lake endemic counties. Mombasa is coast endemic. Now, in simple language for statisticians, you can say, for Migori County, Busia sees twice the number of clients, isn't it? But 5 times the number of clients in Mombasa. But what was catching about this, 2018, 2019, 2020, 2021? With the cases really increased in 2019, And in 2020, really decreased. And we started celebrating, said, oh, the annual malaria incidence is going down. And we said, what did you do right? Then we noted in 2020 is when we had the COVID-19. Then now we have come back to 485. And you check, this rise affected both Busia, Homa Bay, and Migori. But for Mombasa, you can see this line. It's almost constant. What is Mombasa doing that we are not doing for comparison purposes? This is now what they call, we are comparing the cases treated at the health facilities and cases treated at the community units. Allow me use to relate this with marathon. In marathon, if you want to win, you stay behind the pacemaker, isn't it? So number one is the pacemaker, then number two, you keep on running. When you reach the finish line, you take over and celebrate that you have won. Why am I saying this? We have tried as a county to see and confirm, does community case management of malaria work? Now we have been doing marathon. This is community, this is facility, this is the overall malaria cases. And we want to see if the community affects the overall. So we have been coming slowly. I think we celebrated in August 2020. The cases being treated at the community have overtaken the cases being treated at the facility. For economists who are here, for malaria program, community case management is working. But we'll say that after this overall figure comes down. Now, why community case management of malaria? This is just to show you that for these figures you see here, these cases here, we're just giving 1 or 2 L doses to our CHVs, like this. So you can see L6, you only give 2 per CHV, 2 L12, 1 per CHV. We have only 1,500, around 1,050 CHVs. And we give them 5 L24s and 17. But with these minimal doses, they are overtaking cases being treated at the facility. What about if we increase these doses? That's a question for another day. Now, I enjoy seeing this light. So why do we all embrace community case management? It's a dream come true. Why dream come true? Some years back, when they said a CHV can treat malaria, so many people disputed and said, no, it can't work. But today, they have overtaken health facilities. The CHVs, they are volunteers. So unlike many healthcare workers, they don't go on strike. They are available for the community members. The malaria cases are raw. When they have fever, then they reduce severity and deaths. So why do I say raw? For those of us who have worked for some time, you used to notice that most patients in most facilities on Monday, you'll have so many patients. Why? Because the facilities closed over the weekend and at night. So the patients take this, I don't know how we call it in other places, but there's something called Panadol or paracetamol. So they take the drug on Saturday, Sunday, and then they come to the facility on Monday. But with the community case management, they have the AL. They can treat at night, they can treat over the weekend and holidays. Community case management. Then, prompt treatment. Malaria infection is a bite from one person to the rest. If they get drugs early, you reduce the infection. Then communities are available, large numbers of community members reached. Then CHVs do household visits. And there are so many questions we sit in this forum we may not answer. How do the people use nets? What do they do? The CHVs have that chance to tell us what exactly happens in the households. Then there's improved health-seeking behavior. I've said the issue of Panadol. These days, people have the drugs and they couldn't use the drugs. Then they reduced out-of-pocket expense. I request Prof, if we are treating more than a half at the household level, how much are we saving on cost? Very important. Then maybe the second last, cultural beliefs, the issue of use of nets. Some people still believe so many myths and misconceptions. Sustainability. The CHV lives in the village, they know what they do, and they can talk to the rest of the people most of the time. So it is very, very sustainable. These are slides that I'll quick rush through. These are some of the things we do in Busia. We try to do our best to ensure that the malaria case management is managed. This was a visit by the CHVs. I always prefer this picture because this was a very high malaria expertise. I'm also could be knowing Dr. Ozoa from Nigeria and a number of. So we were meeting the sick and asking them, what are your problems? This was a famous statement. We need a lot of local advocacy. Our politicians, His Excellency, the governors, they don't have time. So if you get a chance like this one, you say your problem and it can just be one statement, but package it so that they can remember. That was by Dr. Linda Ozo. This, when we got that message, this our His Excellency, the governor, and this was a malaria meeting. So we presented our case and the county gave us some money to run our malaria services. This is His Excellency, the former deputy governor. We also had meetings. So this is how we package our messages used by these partners. Malaria, why malaria? It is easy for everybody to see. So these are some of the best practices. I don't need to spend time on this. Then let me say something on the challenges. These are our challenges, but if you look at them, they're almost manageable. And I'm happy in this meeting you've said there are funds. What we need to do is to coordinate and see how the funds can assist people. And this brings us to our recommendations. We really wish that we have, one thing we have not done is indole residual spraying. If we added it into our combination, I think we can easily reduce the malaria burden. The issues of electronic medical records and just having what you do operational research. And we are currently working on a research, there's something they call annual malaria incidence. Inside those cases, there's what we call repeat malaria cases. For example, we'll say Busia had 100 cases in 1 year. But in 1 year, the people can get malaria 8 times. So you have counted them 8 times. Lastly, we just need to see how to improve issues of social behavior change. And then we need to acknowledge everyone. Then lastly, those are still acknowledgement. Thank you. God bless all. And have a nice day evening. Thank you.
Thank you very much for that wonderful presentation. You say you are we say this is Professor who? we can give you that title. You have done a good job. You have told us, you have at least given us an idea on what is happening in Busia County with regards to the malaria interventions. I believe, hey, it seems everybody's face is very bright at the end of the day. I am wondering whether you want to ask questions, but I believe you want to go for the next program. And I think it will be in order for us to thank all of you and appreciate your attentiveness. Give yourselves a very loud round of applause. Of course, don't forget to write the questions for the Daktari from Busia County. More importantly, the other questions for the other sessions. If you can have one question, that would be wonderful. The overall chair will guide us on how we proceed. Thank you very much for listening and for participating. Today has been a heavy day. So yeah, we have earned it. And don't forget to thank your co-chairs. Thank you very much.
Thank you, the chair session for this session. Let's give them an applause. They are going to go back and get nurses. It has been a long day, and now it is just me who is standing between you and the dinner and the drink. I don't know whether anyone has a very, very, very burning question. Late in the evening, you can only take one question. Then the rest you can keep them for tomorrow. You know that? A very, very burning question.
Yes, you are the one, Daktari.